Welcome to the Wellness Transcription Podcast, the podcast that combines the power of Christian values with evidence-based nutrition, fitness, and lifestyle content. I'm your host, Dr. Patrick Gurley. Join me each week as we explore the intersections of Christianity and wellness, offering you insights to help nourish your body, mind, and soul. Whether you're looking to improve your physical health or simply strengthen your personal relationship with Jesus, we've got you covered. Stay tuned for inspiring discussions, expert guest interviews, and practical tips to help you live the life God calls us to live. All right. Dr. Harris, I appreciate you lending your time and expertise to come back on here and talk with me about a pretty pressing topic that I've been interested in that I'm starting to see pop up recently. I don't think it's a new topic of that people might not be familiar with, but it's definitely gaining popularity. And that's really this kind of narrative around healthcare where healthcare providers, specifically doctors or pharmacists or what have you, don't make money off of keeping people healthy. It tends to put into a camp of they just want you sick so they can prescribe you medicine so they can continue to bill you and then have their hands in every aspect of healthcare. Now, that narrative I've noticed, especially on social media with a few popular accounts and different podcasts and stuff, it's starting to pop up more frequently. But you're a internal medicine physician, a pharmacist, so you've been there, done that. I just wanted to get your opinion on what you think is contributing to this kind of environment that we're finding ourselves in, and then kind of how you think we could approach it as healthcare providers to get people to realize that that's not necessarily the case, because it seems to be moving in that direction rather quickly.
Yeah, it does. And, first of all, thanks for having me on the show. And second of all, of course, all glory to our Lord and Savior, Jesus Christ, for allowing us to have this conversation today. Man, I really think it was due to the doctors who came before us. And I think most of them were good, but there were some huge scandals. You hear about Medicare fraud. And I think for the notion of being a doctor is still the most respected profession, and I think it's the one that still has the most rarity as far as, ooh, you're a doctor. It's just interesting, how many doctor shows on there on TV, right? So it's a profession that's has this aura about it, and when things go wrong, people tend to remember. And I think that there have been some bad actors, and people now tend to think that everyone's a bad actor instead of that there are just a few rotten apples. And I think it really stems from the fact that people don't understand how doctors get paid. Mm-hmm. Most doctors are employed. I think it's now up to 77% of doctors are not in their own practice. They don't own a practice. They work for a hospital group, or they work for a company that's owned by a private equity company. Or I think United Healthcare employs 10% of all physicians in the country. We can have a whole different conversation about why that's a horrible idea. Yeah. But they're thinking that doctors are getting paid by big pharma for every script that they write. Some, Pfizer or AstraZeneca is dropping off the Brinks truck and just paying us for that. And that's not the case. The Sunshine Act actually makes it so any industry payments to physicians is recorded. It's on a website. I've posted that website. We can put the link down to that website. You can look up any physician in the country and see how much they've gotten paid by industry. And you have to take into account that also means CME. So if I go to a dinner that's put on by a drug company, that's reported as they paid me something because they bought that dinner, which in reality, they didn't pay me anything. I went to a dinner, I got some education on a drug or a product or whatever, and I went home. Mm-hmm. So I think that's the first thing that we physicians need to do is educate people on how we actually get paid. I do not make money for writing a script. There's no drug company that's giving me a kickback. There's no vaccine company that's giving doctors a kickback. In fact, most doctors lose money. Their practices lose money on filling vaccine scripts. This as a pharmacist, vaccines are not very lucrative for the pharmacy. And in fact, they get reimbursed less than a medical office for distributing those vaccines, right? And then you have to look at hospitals. I've been doing some consulting in the billing and coding space for hospitals for the last 2 years. they do not get paid on those infant vaccines. So people think that they're getting paid a lot of money to dispense these infant vaccines in hospitals. When you submit the billing code, there's a code for giving a vaccine. That is not a code that hospitals are getting reimbursed for. So the whole notion of how the public thinks we get paid and how we actually get paid are completely off. And I think that no one wants to talk about it because they're like, oh, physicians just get paid a lot of money. Now it just sounds like you're whining about stuff. It's like, no, I think it's important for people to understand how physicians get paid and realize that us as physicians and pharmacists and other healthcare practitioners, we're not, in general, the bad actors. We're not, no one goes in the pharmacy, well, not no one, most people don't go into pharmacy or medicine, be like, you know what, I'm doing this, I'm sacrificing all this, I'm doing all this hard work just to make a boatload of money. That's my only thing I want to do.
Yeah. I mean, the student loan situation is crazy. I always tell people, I had someone, I think it was on Instagram, and I usually try to stay away from negativity and stuff like that. And I try not to argue with people on Instagram because it's just a waste of time. But I remember I didn't even say anything controversial. I just go, yeah, this isn't true, to some extent. And they just saw that I had like I guess whoever it was went on my page and like, you're a pharmacist, you just shill for meds and you probably make all this money off patients. And I jokingly laughed. I'm like, I wish, because that's just not the case. I didn't spend 4 years of undergraduate school going to all this student loan debt to profit off people. That's just not in my nature. I wouldn't do anything like that. And then again, I think it's just like you said, a fundamental misunderstanding of how healthcare practitioners get paid. In the pharmacy, it's a whole nother rigmarole nightmare of a thing with insurance, PBMs, and things like that. But you can simply look at the amount of independent pharmacies that close every year simply because they can't profit or they can't make enough to just keep the lights on. So if that narrative were true, that all these pharmacists are making oogles of money off of prescribing medications or keeping people coming in and filling those prescriptions, then why would we see all of these pharmacies and even chains to an extent just closing?
Right. I think it's like one independent pharmacy a day is closing right now.
Yeah,
it's pretty astronomical.
There was believe it or not, some friends of mine back in Arkansas, it's a tight-knit group over there where we all go to school and stuff. And there was a pharmacy that's been in the Arkansas area for nigh on like 50 years. And they just announced it at the beginning of February, they're going to have to close. And it's just, it's sad to see that because it's just tricky because by the time you try to get the advocacy groups out there and get attention to what's going on and why these small businesses are going out of business, it's too late. And it's sad to see because like you said, doctors, I think if I remember correctly from the survey that I saw, doctors are the most trusted physician, like healthcare providers still. Pharmacists, I think, are 2 or 3 right behind nurses, I believe. So, it's this give or take of if you live on social media or you're on there enough, you're going to think that everyone thinks this way. And in reality, I don't think it's the case. It's just alarming that it's coming out so out of the gate, so hot now. And then it somehow got tied into politics and stuff.
Oh, big pharma's evil, big pharma this, big pharma that, big pharma's the reason we're sick. And my response is, okay, well, do you want big pharma to sell fruits and vegetables that you don't eat and treadmills and gym equipment that you don't use? So what do you want big pharma to do, to be honest? Now, I'm not saying that they haven't done stuff that's messed up. They have. There are a lot of shady things, and we know this as pharmacists. There are a lot of things behind the gate that just don't make sense, and they are just money grabs. But big pharma worldwide, $1.5 trillion industry. Big wellness, right? All of anything you want to put under wellness, $6 trillion industry worldwide. So you're looking at people who are creating distrust of physicians, and one of the ways that they're doing so is saying, well, all physicians are bought off. They just want to keep people sick, right? That's a way that you can cause distrust in the medical system, but then you can do things like say, oh, well, you know what? I took this supplement or some friend took this supplement and it worked out fantastic for them and they're great, and then sell that supplement, right? So that's why we see literally 4x the market cap in the wellness industry as we do in the pharma industry. And a lot of that is driven by people who are discrediting physicians. They're discrediting research. saying, oh, you can't trust a study just because it's funded by XYZ. No, that's not the case. Funding is something you take into consideration when you evaluate a study, but you don't throw the baby out with the bathwater. And I've even posted before, there was I think it was Nestle. They funded a study on vitamin D and showing vitamin D showing improvement in symptoms for irritable bowel patients. So that is a big food company doing research on a wellness product. I'd say wellness, but it's a supplement, right? So I think that's an invalid argument and something that we're seeing a lot of these grifters do that just really, really upsets me. So the global wellness industry is 4 times bigger than the global pharmaceutical industry, which is astronomical. If it was just about the products, then these pharma companies, or just about the money, it would make sense for pharma companies to stop selling pharma and go into the wellness industry, because they could literally crush anybody in the wellness industry with the amount of cash that they have on hand and their marketing practices and all of that. So the wellness grifters and charlatans, they run the same playbook. It's one, discredit other providers, physicians, pharmacists. They're all bought off. They just want to keep people sick. They're not interested in your health. Discredit scientific research. Oh, this research is industry funded. You can't trust it. Who paid for the study, right? Then the third thing is, trust me, I have your best interest at heart. Look at this super amazing whatever product, supplement, anything that's gotten all of these amazing benefits for these people. Where's the research? Oh no, just trust me, it works. Right? And that playbook is working. It's working very well. And these people are getting very rich off of this. Whereas I literally cannot do that as a physician. So that's what really bothers me, is that these people who are running this playbook are making a lot of money, but are they really improving American health outcomes? No, they're not. I mean, we've spent more and more money every single year on these wellness interventions, yet our overall rates of chronic disease and diabetes, hypertension like that are on the rise. Now, I'm not saying that supplements and lifestyle stuff doesn't work. No, they can work, and they can work very well, but it's all about evidence-based. It doesn't matter if it's a supplement, nutraceutical, pharmaceutical, lifestyle intervention, whatever. If there's evidence to support it, great. If there's not, then we should be looking at other stuff.
Yeah. Give my 2 cents on this one too, because if anyone's done any type of clinical research at all, not easy. Like, for example, when I was doing my master's degree in my nutrition stuff, all I was doing for my thesis project was taking some athletes, different groups of athletes, giving them a survey on just basic, simple health and nutrition related to sports that they were playing, and then just gauging what their education level on it was. And then I would, after I did a baseline test on them, I would then give an intervention, sit down and talk with them via Zoom, educate them on the stuff I was quizzing them about. And then a couple weeks later, they would retake the test and see what they retained. And then I would just compare the scores. Very simple, nothing fancy. It took me a month and a half to get IRB approval to give them a survey through my university. And I did go into, is there any funding? You had to disclose all these things. And I grew up with a father who does clinical research and supplements for his entire career in pharmacokinetic research. And it is a daunting process to just get a study approved, let alone fund it. That's a whole nother avenue. You can go through all of that. You could have the best research proposal, and then you may not get any funding through your grant to do it. And even if there is a disclosure, like, you can look up on all these papers, like, who's funding it. And it's just like, okay, are you really mad about so-and-so big dairy funding a study to find out if this, whatever product it is, if it's beneficial or not? Like, they don't have any influence on how the study is actually conducted. If anything, if it doesn't work, then they're the ones who funded it. So that frustrates me. And then I had a lady come in, and unfortunately this happens all too often at the pharmacy. And we sell a lot of pharmaceutical grade supplements and stuff, but I always take the approach of, what's going on? What have you tried before? Let's try to do more with less, so to speak, when it comes to supplements, because it's not They can't get insurance to pay for it. So it can get expensive pretty quick. I had a lady come in one weekend I was working, and she said that she'd gone to a physician. She was describing some just chronic fatigue type symptoms, pretty broad based symptoms. And she'd gone to a holistic practitioner in here, and she had this list of supplements she wanted me to help her find, like in the store, to see if I had it. And Dr. Harris, I bet this list had 20 supplements on it for her to take. And I'm sitting here looking at her and I'm going, okay, well, can you explain to me why, you went to the doctor, what's going on? And I go, this is extremely excessive. And I go, here's the thing. I go, I could sell you all 20 of these right now. And if you go home and you might feel a little bit better, maybe. And let's say you go home and you feel great and you actually want to know, hey, I feel better. Well, which of the 20 is helping the most? Or which of the 3? And I go, I can tell you right now, based on this list, there's at least 10 or 12 here that don't get absorbed very well. So all you're doing is wasting your money even spending time on it. So I went through, picked out which ones to start and just to help tailor it that way. And she goes, it's funny. She goes, you spent more time with me talking about the actual supplements that I was supposed to get than the person who recommended I do this protocol. And again, I'm all for trying to get to the root cause of things and all of that, but just throwing supplements at people, all that really does is put a big hole in your wallet. And then let's say you spend all that time and all that effort taking these supplements and going through this protocol or whatever crazy diet that they're recommending, and then you feel worse. Mm-hmm. Then what? Mm-hmm. Now you've already distrusted the conventional doctors who, to be honest, the only reason they just don't have the time with their patient load every day to spend 30 to 45 minutes talking to you about lifestyle stuff. And now you spend all this extra money and thousands of dollars on supplements and wellness protocols to not get anywhere. So now you're stuck even more. And it just, this vicious cycle occurs.
Yep.
And it's just, it's sad to see as a healthcare provider myself. It's just sad. And I want to help those people, but at the same time, you got to be evidence-based about it. Otherwise you're not doing any better job than some Joe Schmo person who's selling something on Instagram.
Right.
It's frustrating.
And oftentimes, a lot of times in these functional medicine programs and integrated medicine programs that people are taking these courses for, they're given a protocol, but they don't actually know the pharmacology behind the protocol. Because the people like us, we've had extensive training in pharmacology, right? Mm-hmm. There is no difference at the pharmacology level between a supplement and a prescription medication. Zero difference. In fact, I don't even differentiate between the two. There's things that have been proven to work for certain conditions. There are things that are not. So best case scenario, if someone puts you on a bunch of supplements, they just don't work and you're out of money. Worst case scenario is they actually worsen or interact with each other or cause new symptoms, because that can happen. Some of these supplements, and especially the pharmaceutical grade ones, are extraordinarily powerful. There are randomized controlled studies, our gold standard studies, that will compare some of these higher doses supplements to prescription medication. And I can list a whole bunch of them that show that there are equivalent outcomes. So typically the supplements have less adverse effects, but less doesn't mean none. And anyone touting that, supplements have no adverse effects doesn't know what the heck they're talking about whatsoever.
100%.
They can absolutely have adverse effects. And so you have to be very careful with these things. And really, if someone's not diving into your history and figuring out, okay, what are your goals, and really talking to you about this, and just says, here's a supplement protocol, take it. That's a huge red flag. Huge.
100%.
And I've never started someone on more than 2, maybe 3 supplements. Maybe 3 if I'm using like 2 like mineral or vitamins and then like 1 herbal, right? But starting someone on multiple herbals at a time, it's just like starting someone on multiple medications at a time. You don't know if someone has an adverse effect or if something's working, which one is working. And so there's a whole route that you should go about this. And of course, prioritize lifestyle number 1, always.
Yeah, a couple of things you said there that are really important. Like, for example, I'll give you a perfect example of knowing the pharmacology and how it works. I had a lady come in, and again, this lady was honest, and it was funny because she was saying, I was on Facebook or whatever, and she said, I heard this lady selling some like GI detox program that she listed off some symptoms that I've been dealing with. No, I'm in the back of my head, I'm going, okay, I know her as a patient. So it's like, okay, I know her roughly what her age is. I know what's going on from talking to her often over the last few months that I've seen her. And she picks up this product that they recommended. I'll tell you which one it is. It's called biocidin, which was a big herbal extract. And I've had qualms with this company. I've actually, when I was in pharmacy school, went to a symposium where their rep was there. And I asked her, can you please, if you're going to do anything to help your product, please take the golden seal out of it. And she was like, why are you telling me this? And I tried to explain to her, but golden seal inhibits CYP3A4 drug metabolizing enzymes significantly. Granted, not a lot of it tends to get absorbed because the concentrations of that particular functional group moiety, so to speak, that has the drug interaction is usually in there. But I told her, I go, hey, the reason I wouldn't take this product at all is because it has this ingredient in here. And do you take other prescription medications? And I always ask that question. And she goes, yeah, I take this. And she rattled off a few things. Nothing crazy, but I go, 3 of those right there could potentially be the drug concentrations get increased because of the golden seal that's in here. And I go, and I guarantee you that product's not going to really help you at all with any digestive issues that you're having. And she goes, and she was floored. She's like, I had no idea. I thought it was a supplement that it would be totally fine. I go, that's the whole point. Like, doesn't 90% of the time, I'd say maybe 95% of the time, most of the supplements you take are going to be harmless. But when you start stacking, especially the herbal extracts that are super concentrated, and you start combining that with other things, it can get dicey real quick if you don't know what you're doing.
Yep. I totally agree. And unfortunately, in the market of people who are telling people to take these, they don't know what they're doing. They don't understand the pharmacology, and it's all based upon, oh, just trust me, bro. And this worked for my cousin's baby sister mama down the street, so it'll probably work for you. And it's like, people instinctively know that if I said that about a medication, they'd look and be like, wait a minute, I'm not that person. Like, why would you say that med would work for them in their situation, so it would work for me? But they don't do that with supplements, because the general public separates the two out and thinks that they're different, when in the same, you should apply the same logic you apply to medication as you should to any supplement.
Yeah, it's such a good point. Like, for example, like these protocols that have you start all these different supplements, like you wouldn't do the same thing for a patient who comes in who's newly diagnosed hypertension. Like if they have stage 1 or stage 2 hypertension, you're going to throw 4 medications at them at one time. That doesn't make any sense. You start with one, or you ideally would say, hey, let's implement these lifestyle interventions, get your nutrition in check, and then if necessary, if our numbers aren't improving, we can start this drug and then go from there. Another thing, Dr. Harris, that I've found is this is my biggest pet peeve, is that people, especially on social media, almost expect there to just be cures everywhere. That's another big pet peeve, is like, oh, well, they've found the cure to XYZ disease. There's just no money to be made in curing it. That's why they're not doing it. There's that grift. And then there's also, oh, well, they're not actually interested in curing a disease. Like, the medications aren't designed now to be cures. Otherwise they'd be called cures. Not to say that they can't help reverse diseases, because we've cured actual diseases like hepatitis B, for example. The drugs there, or HIV, can essentially make it to where it's non-detectable. So technically there are a few examples out there where you could identify that, or maybe categorize that as a cure. But like for cancer, for example, this narrative that there's a cure for cancer out there, it just shows that if you start saying things like that you really have no idea how complex cancer can be.
Right.
And that people think, oh, well, whatever protocol got my aunt better from whatever cancer she had. It's like, well, okay, there's a reason scientific research doesn't, like, anecdote is literally like on the very bottom, if not shouldn't even be included in the hierarchy of evidence. And it's frustrating, because I thought that people were a little bit more common sense than that. But again, I don't know where this notion of we've got to find a cure for all these things, I don't know where that kind of came about. Now, I'm all for finding cures for different diseases, don't get me wrong, but at the same time, that people have somehow convinced other people that these cures actually already exist, and that this big pharma curtain has them all stacked in the back, and they're just not sharing it out, is frustrating too, especially when it comes to oncology. Like, I saw a tweet from Callie Means the other day. It literally was a graph of like cancer prevalence incidences projected out over the next 25 years and what the rates are supposed to go up to. And the top line was, don't trust your oncologist. And it's like, really? That's what we're going to tell people, to not trust the cancer experts? So worst case scenario, you have someone who is now going to seek alternative therapies that, proven by the research, actually don't improve lifespan at all. If anything, they actually probably would cause faster rates of decline. And now you're seeking, and then like, I don't see how you could even like feel good about bad mouthing standard of care just to push a narrative that shows that you just don't really know what you're talking about when it comes to cancer. I think that was a big one that frustrated me. Like, really, you're going to tell people to not go to their oncologist if they've got cancer? Like, are you out of your mind?
Yeah.
Like, what protocol are you going to tell people? Are you suggesting that you have a cure for that? Because if you do, I'd love to hear it. But
yeah,
it's weird. I've just never seen that so blatantly accepted. And then you go in the comments and it's just like, it's just weird. I just don't get it.
Yeah.
It doesn't make sense.
It doesn't either, especially like I can go back 10 years and say, oh, when was the last time pharma cured a drug? Well, let me introduce you to our friend Harvoni, right? Mm-hmm. Hepatitis C was a major cause of disease and death, right? Because the treatments that we had for it were terrible. Interferon and, they were just terrible, terrible treatments. Sometimes the interferon was worse than the actual disease itself. Interferon is a nasty drug to give people. And then in 2014, after years and years of research, we came out with a drug called Harvoni. And it was a drug that could cure hepatitis C infection in, I think it's 12 weeks, right?
Mm-hmm. Yeah, it's 3 courses. I think they're 4. Yeah, you're right. I think they're 3-4 week courses, if I remember. And
correctly. You're cured. Like, this had never happened before. Sometimes people would spontaneously remit, or sometimes the previous treatments would cure people, but they were horrible. This was a drug that was very well tolerated in 12 weeks that completely cured hepatitis C infection, right? And this led, hepatitis C leads to liver failure and liver cancer. Mm-hmm. And now you could cure those people. So I'm like, that whole notion that Big Pharma doesn't want to cure people, it's not true. And the cancer thing, I think it stems from the fact that people don't understand that cancer is not one disease. Even if you have lung cancer, there's multiple different types of lung cancer. And even if you have the same lung cancer, your genetic signature could be so different than somebody else's that it's really a totally different disease process. Completely. And the way you treat it is going to be different. So the reason why we haven't seen like, oh, just take this and it cures cancer, because cancer isn't a single disease. Even the same type of cancer isn't a single disease. And different people are in different situations are going to respond differently to treatment. But what we don't talk about is that we've significantly extended life over the last couple of years with some of these small target molecules. People want to talk about precision medicine and personalized medicine. It's happening in cancer right now. The standard of care in cancer is to get a piece of that tissue, do genetic signaling on it, and choose between different regimens based upon that person's genetic signature of their cancer. That's personalized medicine. That's precision medicine. And that's the standard of care right now in oncology. And so what I always tell people, and sometimes people are shocked by this, they're like, well, if you got cancer, you wouldn't take chemotherapy. I'm like, I absolutely would take chemotherapy. I would listen to my oncologist. Now, that doesn't mean that I wouldn't do my own research and try to see if there are other things that have been studied in that particular cancer to help. Because sometimes some of the herbals and stuff like that, they can help one cancer and hurt another. So that's why you can't just say, oh, just take this and you're fine. And then when, looking at things like ivermectin and febendazole, like people are like, oh, it hasn't been studied. They're suppressing stuff. These things have been looked at in cancer treatment. And if there was efficacy, they would be part of the standard of care. And I think that people don't realize that, okay, if you had something that 100% cured cancer, 100%, they could charge whatever they wanted for it. whatever they wanted, $10,000 of treatment, fine. Do you want to be the insurance company that denies someone cancer treatment when it's 100% guaranteed cure? No, that would not happen. It wouldn't happen. That would be suicide for your insurance company. So these narratives are just really bothersome. And it's, again, to paint the picture of somebody else is doing wrong or hiding something from you, but I have your best interest. Trust my process, but also buy my supplements, buy my products, buy my CGM monitor, whatever, something like that. They're always selling you something that is outside of the narrative of what the mainstream's trying to do.
Yeah, it's startling because, again, and what's funny is I see this too. Some people will comment, hey, or they'll say, for example, I'm trying to think, what's his name? Okay, I don't know this guy by any means, but he's popular right now. Gary Brecka is an example. He says some stuff. I'm like, okay, that's not too terribly bad. And he says some other stuff that's so out of pocket. I'm just like, that's just crazy. I can't. Okay, whatever. If you look, the guy used to, correct me if I'm wrong, but I think he used to just sell insurance. And now he's somehow this pinnacle of health and wellness education across the board. And he's super famous now. And it's like, you'll have some people to say, well, what are his qualifications to be giving people this type of health advice? And it's like, well, he doesn't have any. And unfortunately, with this environment of social media now, is everyone can jump in on the game and kind of try to spin it, and everyone sounds the same. If you pay attention to enough of these kind of figures, is they literally all just say the exact same thing over and over again. And I guess you just hear it enough to where you start to believe it after time. But it's weird because these people will tend to, or supporters of that person will die on that hill of be like, this guy did this, and he's got all these celebrities that follow him and look at all this stuff. And they'll say, well, just because you have letters after your name doesn't necessarily mean you know anything. And it's like, okay, I have my own lane. Like, I'm a pharmacist and I have a nutrition degree. I'm probably not going to talk to you about stuff that I don't know about. If you have questions about cancer and oncology, like, I know about the drugs and I know about the side effect management of those things. But outside of that, like, I'm not going to sit here and pretend like I know what I'm talking about. And it's like the same people that will say, oh, well, you just know this or this because your degree was only in this for whatever reason, are the same people that will defend the people that have no degrees that are trying to, like, be an expert in everything. And the hurdles you have to jump through logically to defend that kind of position is odd.
Mm-hmm.
And again, you also have other doctors on these platforms that, because they have an MD, they'll start saying that they're experts in all these other areas. And most of the time, I think they're just trying to maybe give a little bit more information, or it just depends. But when when you tout yourself as an expert in everything, that's a big red flag to me. It just proves that you may not be someone I want to listen to, just because, like, if I don't know the answer to a question, I'm going to admit to you that I don't know. And I'm going to try to either find out on my own, or I'm going to point you into the direction of someone who I do know that does know. And it can give you that sound advice. Mm-hmm. Like, I can't tell you how many times I've punted to experts that I know from being around my dad in the herbal supplement area, or dietetics, or just whatever. It's just like, I'm here, go get this opinion from this person. And I don't know. It's just weird. I think they want us to be experts on everything, but at the same time, like, that in medicine, and that's just not possible. That's why we have specialties, right? I mean,
Yep.
You can't do it all.
No, and healthcare is not an Amazon model, right? And unfortunately, we are in an age where people are so used to everything bundled and, one-stop shop and things like that it gets a little bit hard for them to realize, I might have to go to multiple people with multiple different expertise to solve my issue. And I'm like, yes, because the human body is so complex that there's no one person that can know everything. And, it being internal medicine, we have to know a lot about a lot, but there's still some things that, even with the human body, that I'm not an expert in. I may have a little bit of knowledge in that area, and I know when to refer, kind of like what's warning signs or things like that, but I'm not writing cancer protocols for people, even though I understand a lot of the basics of cancer. There's a lot of the drugs I understand, being a former chemo pharmacist, but treating cancer patients is outside the scope of my practice.
Mm-hmm.
And I think along with that is people don't know who to trust, because a lot of people will post data, but they don't know how to interpret that data correctly. So be very careful when people post studies. How are they talking about the study, right? How are they talking about it in concert with the totality of the evidence? Are they pointing out, even the studies that show benefit, are they pointing out where those areas are lacking in that study? Like I posted one recently about vitamin K2 and vitamin D for coronary artery calcifications, right? If I was a grifter, what I'd say is this study was amazing. It showed that it can help protect your heart. It could save you from a heart attack. And here's a link to my vitamin K2, vitamin D supplement, right?
Mm-hmm.
But what I actually said was this was an interesting study. There is a mechanism for why vitamin K2 and vitamin D could be beneficial for arterial health. In the overall study, they didn't see a difference. But in a subgroup of people who are high risk for coronary artery calcifications, they saw a difference. But as we know, subgroup analyses are often not powered. They're
Mm-hmm.
not robust enough to really make clinical decisions off of. So they lead the way for further studies, right? So now that you saw something in this subgroup, this is something that researchers would want to go investigate. Hey, we didn't see a difference when we grouped everyone together, but this subgroup, there may be a signal here. And that's how I mentioned the study, is talking exactly what I just mentioned and saying, hey, we need further research, but this is exciting given the safety and efficacy profile that we may see in this subgroup. So, yeah, no, you have to be careful about how people are talking about the research, and are they talking about research in like absolutes? Like Mark Hyman is one of my least favorite people on this subject, because he just misinterprets stuff all the time, and everything in his studies he talks about are absolutes. This study showed this absolutely,
Mm-hmm.
and that's not necessarily the case. And
Yeah, tell me you've never conducted a research study without telling me you've never conducted one.
right.
Believe it or not, he's the reason when I was in pharmacy school and just started learning about functional medicine and that kind of thing. It was really interesting at first. And then when I started looking into what it took to get this certification through their institute, I think it was through IF Institution, Institute for Functional Medicine. And they were like, oh yeah, you're in pharmacy school. Like it would cost you, I think it was like $10,000 for me to go through and get this certification. I'm like, okay, let's say I go through and pay this $10,000. Like, am I really going to get anything out of it? And then when you see, and Mark Hyman, I think at the time was all over that program. I think he's still involved, but I can't remember. But again, to your point, he talks in absolutes, and it's like you look at the study, and that's not what it says. Very rarely are those studies ever actually shown. And what I tend to see more than anything is they'll just pop up like a little picture of an abstract. They'll highlight part of the abstract, and then they'll just go see X, look at the results. And it's like, okay, did you actually look at the evidence? What does your actual paper say? What were your methods? Was it controlled? And then, okay, how does this paper stack up against all the other papers? Because if you're constantly the outlier to the totality of the evidence, then we got a problem, because then your stuff's probably not going to be replicated, or it just wasn't done well.
Mm-hmm.
And that's why I always tell people you should always be looking at meta-analyses in these where you're analyzing vast numbers of studies at a time and pooling all that data together to see what you're looking at. But more often than not, especially in a grifter's case, they won't even be able to find a human randomized control trial on something. A lot of times it's just either an in vitro or an animal study that they just take and run with it. Now, like, for example, like I guess banning Red 3 was in the news, which is oddly enough, of all the red dyes to go after, that's an odd one, because Red 3 is not super common as opposed to other ones. But if you look at the studies, and the only reason that got banned was I can't remember the name of the law, but it was essentially that if it, in any of the evidence at any point, it showed an increased risk of cancer in animals or humans, then that was the kind of lawyer way to get that product banned. And if you looked at the studies in rats that showed it was carcinogenic, it was, and then if you extrapolated the amount of milligrams of that dye that they were giving, the human doses would just be astronomical to the point where you could never possibly eat that much red dye at all, nor would you want to. And I think people tend to realize that the reason we conduct animal studies and in cell culture studies is to then find out a mechanism and see what's going on. And then you can take that and then go into the next study, see what you find. More often than not, those studies tend to not translate into human data. Like, you just don't see it happen like that because we're not cells in a petri dish. Like, we're extremely complex biochemical processes that, like I said, me and one person to another can be so different that they just may not see that type of thing, and it's frustrating. It's really frustrating. And evidence-based medicine was one of the harder courses I had. I'm glad we went through it in pharmacy school and in graduate school. Just reading and really dissecting studies and picking them apart is really the only way you can become an expert or even be able to make sense of it when you start diving into that stuff. That's one of the things that I really appreciate about what you do in your short videos is you just go over the studies. There's no angle or anything. You're just presenting the evidence and you're breaking it down really specifically. And it's cool to see because no one else does that. They all just pop up something and then they reference it and then they just either run with it or they just don't cite research at all.
Right. Yeah. And like, yeah, the red dye 3 thing is nuts because so it shows tumor in like super high doses in thyroid in rats, right? By a mechanism that's thought not to be a major process in humans. And Correct. The thing you're talking about is the Delaney clause. So the Delaney clause shows if there's anything that shows evidence of harm in humans, the Delaney clause says, well, we should not have that in our food supply. And red dye 3 was kind of this outlier because it was outlawed from cosmetics. But then at the time they said, well, we really don't think there's enough harm or any harm in humans. We can still leave it in the food supply. And there was kind of some debate about interpretations of the law. So now, finally, they said, well, no, we interpret the law to be this way. The Delaney clause is in effect, so let's remove that from the food supply. And people were championing this. Like the Maha crew were all over this. And I'm like, okay, cool. Like, fine. If you want to have the energy for that, have the same energy for the administration not upholding the menthol ban, which would have been a huge blow to big tobacco. By the way, you never see these wellness grifters talk about big tobacco or big alcohol because that would piss off their 100%. People, right? It's not sexy, but you never hear them go after those two, which are probably, if you wanted to make America healthy again, that'd be the quickest, fastest way to do so is by decreasing alcohol and tobacco sales.
100%. You talk about decreasing cancer risk, cutting alcohol out is probably and again, I still hear this, and you've debunked this on your own channel. I've heard it. Even the I can just have a drink or two a night, like, and that's healthy, because that kind of was the kind of I don't remember what study that came out of, but a while back that kind of took hold. And it's like, no, in reality, if you look at the data, like people who consistently have 1 or 2 drinks a night, their risk is so much higher. Like, it's just not, we know this, like there's not anyone out there touting that alcohol is beneficial. Like, there's really nothing positive that can really come out of it. But oddly enough, I hadn't heard anything about this menthol cigarette ban until I knew the Biden administration was talking about getting rid of it, but okay. And then I'm surprised when I saw your page today that they were going to reverse it. I'm like, why? What's the logic? Like, it doesn't make any sense.
It doesn't for people, but tobacco is a big, powerful lobby, right? And the menthol ban, it's 37% of sales are menthol cigarettes. So just think about it.
I didn't know it was that high.
It's huge, which we don't think about it because, like, I've never seen people smoking menthols, but, like, I'm not in the communities that are marketed to for that. It's been repeatedly shown that menthol cigarettes are predatorily marketed towards communities of color. So the people who are already more predisposed to chronic disease they get predatory marketing for alcohol and tobacco and fast food, right? So these are the communities that could benefit the most from this. And once again, the administration prioritized corporations, which any of us who followed, I'm not anti-Trump. I think in his first presidency, he did some things I liked. He did some things I didn't like. Just like every single president who's ever existed, he did some things I liked. He's did some things I didn't like. She's done some things I liked. She's done some things I didn't like, right? That's just politicians. They're not going to do everything that you like. But in general, Trump has favored big corporations and deregulation. So it's like, okay, this guy who's favored big corporations and deregulation is now supposed to come in and regulate these same big corporations. Like, I didn't think it was going to happen. And then the not upholding the menthol ban was really the first sign that it's just more of the same, right? This is something that could have actually made a big difference in the health of Americans. And we prioritize corporate profits once again.
Yeah, it's unfortunate because one of the big key pillars in my nutrition education journey was when you go into these communities, these underserved communities, they don't have the economic prowess or ability to buy the type of foods that you would want them to have. Those are the types of communities that if you're going to implement a program to get these healthier food options, then we should make that even easier for those types of people, because those are the people that are living in a food desert, and people think a food desert just means there's no food around. It's like, no, they might have access to food, but it's mainly calorically dense, highly processed foods. It's just when that's all you can afford and that's all you have access to, it would be very unbecoming to me to go, oh, you just need to go to the grocery store and buy all the meat and vegetables that's now more expensive across the board. It's not easy to, let alone, let's say you could afford to buy the recommended amounts of fruits and vegetables one would need to really have some impact. Now you got to worry about, okay, well, how do I prepare those? Do I have the time? I have 4 or 5 kids. Like, people are busy. It's not easy. Mm-hmm. And it's really sad that you have a lot of these people online that are telling people what to do, how to be better and stuff, when in reality, they can't see that they live an entirely different existence than these other people. And to just say, oh, you just have to go buy organic and buy all this stuff and you'll be fine and actually be disciplined. It's like, that's no better than me just saying, oh, eat less, move more. It's just not, you just haven't been around the people that struggle with that type of stuff.
Right.
And that's the big thing with, another thing I wanted to add to mention to you was with all the GLP-1 stuff going around. I don't know where this narrative came around that there's a lot of people in the Maha movement that are very anti-GLP-1. And I didn't quite understand why. Jillian Michaels was one of the people that they just start touting all these lies about these types of medications. And it's like, okay, wait a minute. If we want to end chronic disease and we want people to be healthier, and we know exercise and eating better helps, obviously. But we've known that for a long time, and people still struggle with these types of things. And now there's a drug option out here that's, yes, it's expensive, but it's becoming more available, and eventually the market will work that out. And it's actually helping these people lose a lot of weight in addition to the lifestyle interventions that you already want to implement. And they're losing significant amounts of weight to where now they can be more active and they can go to the gym more and they can do these things and they're in less pain. And now you somehow have a problem with it. Like, it just doesn't make sense to me. It's like, you'll hear, oh, you're on them forever, blah, blah, blah. They cause all these issues. They'll say they cause tumors. And it's like, no, these drugs have been around for a long time. Ozempic and Victoza, these drugs have been around quite some time now. And we have some long-term safety data on them, and we do know the risks and benefits, and we do know what to do if you're on those to minimize your risk of said events. But now it's a problem all of a sudden that people are using those. It's almost like a stigma of like, oh, you used Ozempic, you cheated or whatever. In reality, you want big pharma to stop profiting off people, but at the same time, they come up with a drug that actually helps solve one of the main chronic disease burdens that we have, and now you have a problem with it just because big pharma came up with it. It's weird,
right? Yeah, I mean, I've probably read every single GLP study that's come out in the last 2 years, right? And the first one, exenatide, Byetta, came out when I was in pharmacy school, so that was 20-something years ago, right? We've known about GLP for a long time. They just aren't stable. So anybody who says this is nature's GLP or it increases GLP, doesn't matter. GLP has a half-life of seconds. It means once it's made, it's cleared in your body within seconds, right? So what made these drugs great is that we figured out how to extend the half-life, meaning how long the drug can stay in the body. So, the first GLP, Byetta, I think it was injected twice a day, if I remember
Yeah, it
correctly.
was. It used to be twice a
Yeah.
day. Mhm.
And then, we came out with once a day, Victoza, and then once a week with Trulicity. And then we figured out how to actually make it more potent with semaglutide. And then tirzepatide is, GLP, GIP, and now there's triple ag. So that field is not going away.
Yeah, I think what's the new one? Is it retatrutide?
Yeah.
I think that's how you say it. I think it hits 3 different.
Yeah, that's a
things.
triple agonist, right? So, and there's other ones in the pipeline too. So if you look at the adverse effects, I mean, they're gastrointestinal. They tend to go away. It doesn't cause people are like, oh, it causes gastroparesis. For the first 30 days, it slows down gastric emptying and the body adjusts. There was actually a study that looked at this, and it showed that the gastric emptying after about a month went back to normal, right?
Mm-hmm.
I think a lot of the adverse effects are due to poor patient selection, right? And then poor counseling on how to mitigate some of those adverse effects, right? If you're obese, it's probably because you're overeating, right? And now we're putting you on a drug and you cannot eat like you used to eat beforehand. I would always tell people the moment I put them on the drug, decrease your intake by 10%, right? At a minimum, just so you don't overeat, so you don't get that sensation of fullness, like the too full that can make you nauseous. Remember your water intake, because sometimes people, it will affect their thirst. So some of the adverse effects we see are because of that. People aren't intaking enough water. And then, as a nutrition masters, people can get like a liter of water a day from their food. So you can get a significant amount of your overall water intake from the food that you eat. So now you're decreasing that. So that's a big issue. I also think, again, patient selection. I'm very leery on using anybody who has had a history of bowel obstruction or who's had a history of gastroparesis, right? People who have already been depressed. There is a signal there for, it doesn't seem to be so in people who had who weren't depressed, becoming depressed. But for some reason, there's a signal there that it may be a problem in people who have pre-existing depression. We haven't seen any thyroid cancers in humans, right? We haven't seen really any pancreatitis. That's more of a mechanism, but clinically, it's hard to ascribe because people who are on it have high risk factors for pancreatitis anyway.
Yeah.
So, overall, I think these drugs have an excellent safety profile when patients are selected appropriately and when patients are counseled appropriately on how to watch out for potential adverse effects, and they're highly effective. So I don't know how you can say, oh, Americans need to lose weight, and then we come out with a way for Americans to lose weight, and then the muscle mass, right? So we don't actually know yet. There's no evidence of actual muscle loss, because if you look at DEXA scans, when they look at lean mass is muscle, it's water, it's connective tissue. And I used to be one of these people that worried about that lean mass, but then you see people when they lose weight, they increase their activity, they feel better. And I think what will actually happen is now we have CT scans where you can do a CT scan and it can actually look at intramuscular fat through some of the new protocols and machine learning. I think you'll see a study here in the future where they do these CT scans. And my guess is you'll see a decrease if your protein intake is adequate, of course, and your resistance training, which are part of the lifestyle recommendations that come along with this, that you're going to see a decrease in overall lean mass, but I think it's probably going to be a loss of that intramuscular fat. And so overall, your muscle tissue is healthier, right? I think that's what you would see. And I'm really interested in looking out for research in that area using some of these CT scanners that can look at intramuscular fat.
Yeah, two things about the drugs that I've noticed from me being a pharmacist. I get asked these questions all the time now. One, another thing to your mention, like when you're a clinician and you're prescribing these things, one of the big things that I always tell people is if you have a history of any eating disorders, specifically anorexia, we need to not go down that rabbit hole, just because it can stir people back into that camp. And I think another interesting thing, and I heard this term when I was in school, was food noise. And I'm like, what is food noise? What are they talking about? And then you start to listen to these people that would be like, yeah, I just really struggled at night with either binge eating, or I would restrict during the day and I would get home and then I would just lose it or whatever. Or was constantly craving this or that. And you're starting to see people saying the way I crave foods are different, or I don't have those cravings anymore, which is great because when you don't have those cravings, you're not wanting to go eat those things, and inadvertently you're dropping your caloric intake and you're not even thinking about it. And again, people that have a bunch of weight to lose, I've had family members that have been on the medications, and one of them in particular has told me that he doesn't have knee pain anymore. He goes, I can get up and go. He goes, I still struggle in the gym and stuff. He goes, but I can still get up and go walk around. I can go walk on the treadmill for 30 minutes to an hour. I didn't used to be able to do that. And those are victories, whether we want to see it or not. And I tell people all the time, like, don't expect this weight loss on these drugs to be linear either. People think that once you start, it's just this amount of weight's going to come off this fast over this period of time. And it can fluctuate. Some people, the scale may not move a whole lot, but how do you fit well? Do your clothes fit better? Are people noticing? And again, there's only really positive things that I've seen so far. I don't know where that narrative of gastroparesis came about, but I think if I recall, there was I think a Daily Mail article or some news outlet picked it up, and a lady had actually been on 2 different GLP-1 medications at really high doses, and she'd had actual gastroparesis history. So it's like, okay, you have someone taking 2 of the same drugs, so we're duplicating therapy now, and they already had a history of this, so they shouldn't have probably been on the med anyway, let alone 2 of the same thing. So you then took that, wrote a story, and then ran with it, said that it's going to paralyze your stomach.
Right.
It's like, come on. If that were truly the case, all the diabetics that we've had on these drugs for the last 10 to 15 years would have had gastroparesis by now.
Right.
We just don't see that.
Right. And they're the highest risk for developing
100%.
gastroparesis. And I think you bring up an interesting point is the pleiotropic effects that we see with this medication. And pleiotropic for us is meaning one medication, multiple different effects, multiple different systems. The sleep apnea, right? Just approved for sleep apnea treatment. And we've known that weight loss can help with decreased severity and sometimes even cause remission of sleep apnea. So it was great to see that it helps people who have obesity and sleep apnea, because sleep apnea is a disease that's not talked about enough. It is a devastating chronic disease. People can die. You can die in your sleep from sleep apnea, but it can lead to cardiac events, poor cognition. So that's one. The bone effects. So semaglutide, tirzepatide, the GLPs actually have anti-resorptive effects. So they actually help stimulate or help prevent the breakdown of bones. And so we've seen in clinical trials, people with obesity and arthritis show improvements in joint pain. Anecdotally, I've seen people who have autoimmune diseases who are a little bit insulin resistant and obese improve the symptoms of their autoimmune diseases. Addiction, so substance use. We've seen a signal there for alcohol. People would drink less when they were on these medications. So I think we're just scratching the surface of the different effects that we can see. And I think some of them are related to obesity, reducing excess adiposity. So I think some of them are independent of that. I think there's probably the insulin sensitizing effect. We know in, pharmacodynamics, they are anti-inflammatory, anti-resorptive. And I think they're changing the notion of how we think about satiety, because there's no reason I can think of, like, in their mechanisms that we thought of before, of why they should decrease people's alcohol consumption. The only thing I can think of is that satiety is a much more global concept than we previously had thought.
Asked me about it, and they were talking about that just out in the store. They were talking about how they don't drink as much anymore. And I asked him, I'm like, okay, I know I've heard that a lot. I've had, again, family members or friends of mine who I know are on the medication say the same thing. And what's interesting, they try to ask them like what that presents like. And a lot of them have told me that, one, they just don't crave it or they don't want it. But more often than not, I've heard that stuff tastes stronger. So like, for example, if you're someone who drinks like stronger alcohols like whiskey or higher proof alcohols, even at lower proofs of those similar things, it tastes like it's a way higher proof, and people tend to not like that, which I thought was interesting. And again, they're starting to tastes and what they crave and stuff starts to change. So there's definitely the signaling and stuff that's going on there is obviously more complex. Nothing really in science is this kind of simplistic way, because all the mechanisms are tied together for the most part. So it's important. But again, I think these these things as we learn more. And it's really going to be interesting to see how AI comes into play with all of that, especially with the research side of things. I'm really excited to see. Now you can just find whatever you need and use these multiple language models to find studies that you're looking for so much faster. So it's really interesting to be in healthcare at this point.
Mm-hmm.
But one last thing I wanted to talk about, because me and you could talk for a long period on a lot of different things. I wanted to bring the kind of conversation full circle on how, as an internal medicine primary care physician who has all this knowledge, how do you, from a primary care perspective, how do you think primary care doctors should handle this, the way that primary care is moving, and how can we take the model that we have currently that's obviously not great by any stretch of the means, and how can we modify that through this model? So you've mentioned you're working on a new direct primary care model yourself. What does that look like, and why did you decide to go that route as opposed to your typical primary care office that you've obviously been in before?
Yeah. So I worked in a big box primary care before. I hated it. I was seeing 25 to 30 patients a day, on call in the hospital once a week or once a month for my patients, and on call every weekend for all my patients. It was miserable. And I had about 1,200 patients that I was responsible for.
That's crazy.
Right? I can't think of another job where you have like directly downstream from one person is 1,200 people. Right.
Yeah, I knew it was high. I didn't think it would. You would. That's insane. Of course, you don't have time to spend 30 minutes with each. That's insane.
No, I
couldn't.
There was a study that came out that said to meet guideline directed care, primary care physician would need to see patients 28 hours a day. So, simple math says that doesn't work out. Right.
No, it wouldn't work out for very long.
Right. So, I think there's a couple things we need to do for primary care. Is one, get the ownership back to physicians, right? Like I said, 77% of physicians are employed. That obviously is not working. Number two, last time I looked at it, we only spend about 7% of the $4 trillion that we spend in preventative care, right? So better reimbursement for preventative care, primary care services would mean that you don't have to stack a whole bunch of patients in your day to make revenue, right? Because now you're getting reimbursed better for the things that you do. Imagine asking a surgeon that they had to operate on 28 people a day, right? They don't have to do that because they get reimbursed better. Plus, they don't have the time. They actually get to, make sure that they spend time doing the surgery. So I think that's going to take a lot of regulatory changes. In the short term, direct primary care is an option for a lot of physicians. This is a subscription-based service, so you pay a monthly fee. These physicians usually cap their practice at most as 300 patients, right? So about a fourth of the size of what I was seeing before. And now you can really set the terms of how you interact with your patients. Some practices, they dispense medication, so they will get medication cheaper and dispense it to the patient on cash basis. They integrate labs into the practice, so that's usually included in your monthly fee. And then you get to spend unlimited time with the physician, right? So you really get to dive into all of these social determinants of health, environmental factors, dive into lifestyle, really come up with comprehensive plans, and then work somebody through a plan, right? Because I can now meet with someone every 2 weeks in the direct primary care system. And we can really check in and build that relationship and kind of grow together as we achieve our goals. So I'm really excited about direct primary care as an avenue to free up physicians to practice how they want to practice and have patients interact with their primary care, how patients want to actually interact with their primary care docs.
Yeah, that's the model I know with my employer. We've gone to a direct primary care result. It's been great. I can text my provider when I need them. We can have long conversations. It's not a big giant waiting game trying to get in to see somebody. If you need to go see a specialist, you can. Mm-hmm. It's just a much easier, more feasible thing. But again, I would much rather have physicians go to that model and figure it out. And just like you said, as the regulatory change needs to occur, which it will, but it takes time. All that stuff takes time. The answers are there. And I think that's what I think also that model, I feel like, is going to answer a lot of the things that we've talked about today on the problems that we currently see. It's like, how do we combat the narrative that these doctors want us sick? And it's like, well, if you have a direct primary care practice where you can invest in your patients, those patients are going to realize pretty quickly that that's not how the system works.
Right.
And you can spend, because again, if you only have 5 minutes to see a physician, they walk in, you give them a brief, you tell them what's going on, and they're like, okay, he's got some inflammation or whatever. Here's this medication. That's really all you can do in that short period of time.
Mm-hmm.
And if you have to see 30 to 40 patients a day, like that's insane. I mean, that filling a lot of prescriptions as a pharmacist per day is daunting. I couldn't imagine trying to pinball and chart and do all the stuff that you need to do to get reimbursed for seeing those people. It's just a lose-lose situation. So I'm excited to see that field expand. I'm excited to see how you do in there, because I mean, we've been friends long enough to know that you do a great job. I'm not
Thank you.
tooting your horn or anything, but like, if we have more physicians out there that were in this space, that we're able to invest in patients and see that it is feasible in the current healthcare environment that we have, I think we'd make a lot of headway pretty quickly.
Right.
So I'm excited for that. Anything I can do or we can do to help, let me know. I appreciate the time. Is there anything else pressing that you want to chit chat with before we call it? We're about an hour and 10 in here, and I don't want to keep you on here all the time.
I think we covered a lot of different hot topics. So.
Yeah. Well, I appreciate it, Dr. Harris. Thank you, man. Give my best to your wife, and just keep us updated, okay?
Will do, brother.
Thank you for joining us on today's episode of the Wellness Transcription Podcast. We hope you're inspired to live a healthier, more purpose-filled life in Christ. Remember, your well-being is a gift from God, and by taking care of your body, you give Him the glory. If you enjoyed today's episode, please subscribe, share, and leave us a review. We'd love to hear from you guys. Your continued support helps us spread this message of health and faith. Until next time, may God's grace and good choices guide your path to a life filled with joy, vitality, and a deeper connection with Jesus. God bless you all, and we'll see you in the next episode.